Have you ever been a part of a code that felt like this? I know I have. Hi there, my name is Dominique Suriano and I work here in the emergency department at Sutter Medical Center, Sacramento. I have been with Sutter for 14 years, and in my time, I have seen my fair share of cramped code rooms. As a result of the recent pandemic, however, Sutter Medical Center has put together a policy and plan for us in order to keep ourselves and our patients safe during these difficult times. This presentation will review some of those changes and policies and improvements that we've implemented into our code process that will help you at the bedside provide better and safer care. Thank you. Hope you enjoy. Key changes and improvements. In the past, codes have felt chaotic. There were often undefined roles, rooms were loud and full of people, which made it difficult to hear and adequately care for critically ill patients, and staff had deviated from wearing appropriate PPE, which was a major infection control issue. The procedures during codes, such as chest compressions, bagging with a bag valve mask, and intubations are highly aerosolizing. Aerosolizing procedures put staff at risk. Therefore, it is imperative that we limit staff presence in the room and wear appropriate PPE such as PAPRs, gowns, goggles, and masks to improve not only patient care, but also decrease infectious disease exposure to our team. Limiting staff in room. These needed changes and enhancements to our Code Blue process here at SMCS have also led us to realize the importance of not only limiting staff in the room, but ensuring these staff members are highly trained and have standardized processes in place. These highly trained staff members include 2 rapid response nurses, or RRT, 2 respiratory care practitioners, or RCPs, and the intensivist or provider. Ensuring these team members enter the room during a code ensures consistency in care and safe patient handling during at-risk procedures. The responsibilities of each team member, both in the room and outside of the room, are of vital importance. The next 2 slides will provide a written description of each team member's role during a code here at SMCS. Responders and responsibilities. The RRT nurses, or Rapid Response Team nurses, act as the defibrillator monitors, medication administrators, IV and IO access, and can also provide chest compressions when necessary. The RCP practitioners, or respiratory care, assist in airway management and can also act as compressors. The intensivist or provider acts as the lead and will intubate the patient when necessary, while the primary nurse acts as the communicator for staff inside and outside of the room. I'll go over this process more in detail on later slides. Responders and responsibilities continued. These responders would be the responders outside of the room during a code. The charge nurse from either MICU or Med-Surg brings the isolation cart down from his or her unit, while the charge nurse or any other staff member from the floor brings the crash cart, Zoll, and backboard. They also provide a staging area outside of the patient's room. The house supervisor acts as crowd control, ensuring only essential staff are at the staging area by the room and inside the room during the code. The pharmacist prepares medications and anticipates next medication needs from outside of the room. They work with the communicator or the primary RN and the house supervisor to hand off medications to the essential staff inside the room. Nursing assistants may also be present in the staging area outside of the room to serve as runners for supplies needed during the code. Inside the room, again, you'll have the 5 essential staff, which would be the provider, the respiratory therapists or RCPs, and the RNs or the RRTs. It is imperative that only the 5 essential staff are present. However, it may be possible that the MD or RRT nurses make an exception to this 5 essential staff in the room and request additional support during a code. It is then essential that the outside staff be prepared to provide assistance, whether it be with medication administration or compressions, inside of the room. Again, the tasks that the RRT nurses or the MD ask of you will only be tasks that you can provide in your scope of practice. And of course, you will be required to don appropriate PPE at that time. Outside of the room, you will have the house supervisor, the pharmacist, the primary RN, who acts as the communicator between the inside and outside staff, and a code charting RN, which oftentimes is the charge nurse of the floor. You might also have NAs to be runners, and then you'll have the crash cart, computers, charting, and any extra supplies. Here is an example of the PPE cart that will be brought down from the MICU or Med-Surg charge nurses. This cart will include PAPRs, a video laryngoscope, RRT bag, CT clamps, a viral filter, masks, gowns, and goggles. It should be noted that RRT will come with their own earbuds and Cisco phone. If, however, they do not, on top of the PPE Cart, there will be a walkie-talkie backup that can be used in place of the earbuds. It should be noted that the walkie-talkies are often difficult to hear, so closed-loop communication is essential. Additional carts, similar to the one shown in the previous slide, are used in the emergency department and L&D floors. These carts contain extra supplies for these departments based on their patient population needs. Some areas like ED and L&D also require extra staff beyond the essential previously discussed 5. Viral filter and 2-hand seal. Although not recommended if not a part of the essential staff entering the room for a code, there may come a time when bagging the patient is necessary. If that is the case, it is important to remember that the viral filter and 2-person bagging is required. The viral filter is used to contain airborne particles. The first staff member assisting with the BVM uses the 2-hand seal method to prevent escape of airborne particles, while the second staff member squeezes the BVM bag to administer ventilations to the patient. Again, this should only be performed if absolutely necessary under the direction of an MD. Otherwise, high-quality chest compressions are the main focus until essential staff are available. So, how do we get to this point where essential staff are present and everyone knows their roles and responsibilities? Well, this process likely first starts with a first responder. The first responder in this situation is the person that finds the patient in need of a code blue intervention. This team member will likely be an NA or the primary RN on the floor. This first responder will also likely only have PPE needed for normal day-to-day care on their floor. PPE may depend on the patient's COVID status, but will likely include either a surgical mask or an N95 and goggles. Because of this, the first responder will only perform compressions and will call a code blue. The first responder will provide chest compressions for the patient until an essential team member enters the room. Essential staff will not provide the patient ventilations by bag valve mask until the first responder has left the room because of their lack of appropriate PPE. Once instructed to do so by the essential staff member, the first responder will leave the room. If the primary RN, they will then act as the communicator, and if they're an NA, then they will stand by in the staging area for further instructions from the house supervisor. The first essential person to enter the room after a code is called will likely be the RRT or rapid response nurse. Their role upon arrival is to first don appropriate PPE and take the Zoll and backboard into the patient's room. With the assistance of the first responder, the RRT will place the Zoll pads or defibrillator pads on the patient and assess and treat if a shockable rhythm is present. They will also place the backboard under the patient and take over compressions from the first responder. Once given approval by the RRT nurse, the first responder can exit the room and either act as the communicator for inside and outside staff if they are the primary RN, or don appropriate PPE and re-enter the room to assist the first essential team member until other essential staff arrive. This entire process should be under the direction of the essential staff member or RRT nurse. The next slide will provide a video example of how this process will look and how the transfer of care should take place. This illustration shows the layout of enhanced CPR safety process. Your 5 essential staff are located on the inside of the room, and the nursing supervisor is standing guard at the door to ensure only the 5 essential staff are in the room. Notice that the crash cart remains outside of the room so that the pharmacist and other outside staff can retrieve supplies to hand into the room. You'll also notice that if the crash cart is outside of the room, the Zoll must be removed from the crash cart and taken inside of the room with the essential staff. The first essential staff member with the appropriate PPE will bring the Zoll and backboard into the room and relieve the first responder who is providing compressions to the patient. In the next 2 slides, we will break down this process in a video animation. But before we begin, I would like to reiterate the importance of avoiding BVM prior to intubation with COVID and PUI patients to decrease aerosolization. If it has been determined by the provider that the PUI or COVID patient does need to be bagged prior to intubation, a viral filter and 2-hand seal must be used. For patients that are already intubated, they will remain on the ventilator and increase the FiO2 to 100% if bagging is required. Again, a viral filter must be used. Here we see the primary RN checking on her patient. She finds her patient unresponsive and immediately calls a code while providing high-quality compressions. She will continue with compressions until essential staff arrive to relieve her. During this time, the 5 essential staff are arriving and waiting for appropriate PPE. The charge nurse from the floor also arrives with the crash cart, Zoll, backboard, and computer for documenting the code event. The MICU or med-surg charge nurse will also arrive with the PPE Cart. The 5 essential staff will then don appropriate PPE. The house supervisor will also arrive. Once the RRT nurses have finished donning appropriate PPE and ensuring that their Bluetooth device is functioning, they will enter the room. The first RRT nurse will bring the Zoll and backboard. If for some reason there's only one RRT nurse, the primary RN or the staff member that found the patient will assist with backboard placement and ensuring the pads are placed on the patient. If, however, 2 RRT nurses come at the same time, as shown in this video, the primary RN or the person who found the patient will then be relieved of their duties. As shown here, the RRT nurse tells the primary RN, "I will take over CPR and you will go act as the communicator." It should also be noted that during this time, the pharmacist should arrive and the charge nurse should prepare to act as the documenter for the communicator outside of the room. As the primary RN, the communication role is very essential. It is important that you maintain quality communication with both inside and outside essential staff. While the rest of the essential staff are donning appropriate PPE, it's important to note that it's possible you may see more people in the staging area than necessary. It is then up to the house supervisor, as shown in this animation, to act as the gatekeeper. For example, the house supervisor might say, "The NA can stay and act as a runner. All other non-essential staff need to leave at this time." It is important to remember that if you are a non-essential staff and are asked to leave, it is only to ensure continued staff safety and that the area remains quiet and calm so that the communicator can maintain closed-loop communication. Here you can see the first responder has activated a code blue and initiated chest compressions on the patient. The first essential team member has arrived, an RRT nurse, along with the floor charge nurse who has brought the crash cart, Zoll, backboard, and computer for documentation. The RRT nurse will then don appropriate PPE, including a Bluetooth earpiece that connects to their Cisco phone. This allows the essential staff member to communicate with the outside staff and also participate fully inside the room during the code blue process. Here you can see the RRT nurse has verified with the charge nurse or charting RN that she can hear through her Bluetooth device and continues to don her appropriate PPE. After the RRT nurse has donned appropriate PPE, she will obtain the Zoll and backboard and enter the patient's room. Under the direction of the RRT or rapid response nurse, the primary RN, as displayed in this video, assists with continued chest compressions, pad placement, and board placement. The essential RN or RRT nurse then gives the okay for the first responder or primary RN to exit the room and act as communicator. Closed-loop communication. In the next slide, there will be an animated example of the importance of closed-loop communication and how it plays a vital role in the code blue process between the RRT nurse, the communicator, and the charting nurse. Here is an animated depiction of a patient's room during a code blue and also closed-loop communication during this process. Inside the room, you will notice 2 RRT nurses, 2 respiratory care practitioners, and an MD. You will also notice the Zoll and backboard are present in the room. Outside of the room, you will notice there's the house supervisor, the pharmacist, the nursing assistant, the primary RN who will act as the communicator, and the charting RN. As an example of closed-loop communication, you will see the RRT nurse communicate to the outside communicator 1 amp of epi given at 1330. The communicator RN will then repeat that statement, 1 amp of epi given at 1330, to the charting nurse. The charting nurse will then repeat that statement, 1 amp of epi given at 1330, charted. This type of closed-loop communication during a code blue event decreases care and documentation errors, ensures that all patient care is documented appropriately, and also provides a clear understanding of the care being provided behind closed doors. Summary of information. Throughout this presentation, you were provided detailed information regarding the new process for handling code blue events here at SMCS. If you are unfamiliar with these types of isolation or any other processes mentioned above, please refer to Policy Stat, your manager, or your educator on your floor. Patient and staff safety should be our number one priority in these difficult times. It should also be noted that regardless of your patient's isolation status, if a code blue is called, the above-mentioned plan of only 5 essential staff in the room during the code remains the same. Ensuring continuity of care for all patients during a code blue event, regardless of their isolation status, ensures consistency in care and safe patient handling during at-risk procedures.